Any clinician working in the midst of a myopia epidemic knows axial strength and refractive error. But one less heralded measurement may hold the key. Pupillometry is often neglected, but Singaporean Dr. Chen-Hsin doesn't think it should be. He joined us to talk about why this measurement and how Topcon's MYAH leverages it at one of the busiest myopia clinics on the planet.
We know that from randomized clinical trial using atropine to treat children with progressive myopia, the landmark study from the ATOM study in Singapore, as well as the LAMP study in Hong Kong, both show that higher dosages of atropine leads to a larger pupil size, as well as a better treatment response in controlling myopia. We do not know whether larger pupil size directly contribute to the better effect of myopia control, but we do know that a larger pupil size causes photophobia, the side effect of atropine. So children complain of sunlight being too bright when their pupils are large. So when we start patients on atropine eye drop, we want to know whether the drug is getting into the eye and whether the eventual axial length elongation is under control. So MYAH, together with axial length measurement, has this pupillometry function. So we can look at that and see whether the pupil response is affected when we start the patient on eye drop. So here I'm showing a case of a patient started on 0.025% atropine, and you can see the pupil is fairly dilated and the pupillary response is sluggish. So this patient do have photophobia, but we also started the patient on photochromatic sunglasses. So the patient is able to tolerate the eye drop. And you can see from the axial length elongation graph, once we started the patient on atropine, the axial length stopped progressing. And you can see that on the growth chart as well. When I want to decide whether a patient should be increased or decreased on a different dose of atropine, I can look at the pupillary response and determine if the pupil size is already very big, like this case, a 0.025, then giving the child on 0.05 will have made the pupil size even bigger and patients will have more side effects. When the pupil size is already this big, we know that there is sufficient amount of atropine that is going into the eye. And so that tells us that there's no need to change the response. Conversely, if a patient is on a specific dose and the pupil is still very reactive, then we should consider increasing the dosage, as we know that the patient probably won't have that much side effect. So it is an infrared video recording of the pupillary response in response to a standardized dose of light. And it's a continuous recording with segmentation of the pupillary size. So I've showed two videos, one on a patient before starting on 0.05% atropine and after starting on an eye drop. And you can see a dramatic difference between the pupillary response from the video, as well as the numerical numbers that is shown on the graphs. So this is the only device on the market at the moment that gives you this video recording capability as well as numerical analysis. This is beneficial in terms of having the video to show the parents the effect of the eye drop, and also having the growth chart to show and let the parents understand where the child is in terms of their axial length. So in terms of patient education, it helps me explain things faster. It does take a lot more time in terms of getting the kid to do all this measurement, but that's done at the front end by your technician. So once you have that workflow going, and also having the software installed in your clinic computer where you can have the machine outside and the software inside, I think that helps with the clinical workflow. The first line of treatment for me personally is still peripheral defocus spectacle lenses. So for these patients, we can monitor their baseline response in pupillary response, and then we can look at on subsequent follow-up when the axial length, if there is progression, then we can decide whether we want to add atropine eye drop, and we can base on the pupillary response and look at adding the eye drop, whether there is a huge increase in pupillary reaction or there is none. If there is none, then we can increase the dosage further. All the optical intervention that we have, be it orthokeratology, soft contact lenses, as well as peripheral defocus spectacle lenses, all of them work better when the pupil size are larger. And that's because the optical effect of the lenses can get into the eye. And many studies have shown that there are synergistic effect when you combine the two together. So ideally, you want a larger pupil size as much as the patient is able to tolerate. So MYAH tells you that exact pupil size. So you can look at the pupillary response and titrate your atropine to achieve a larger size as much as possible. One tip that not many people would have thought of is using pupillometry as monitoring for compliance of eye drop. So in this video, this child is supposed to be on 0.01% atropine. But when I looked at the child under the slit lamp, I already see that the pupil is very reactive to light. And when you put it on a MYAH, and you can see that the pupil is reacting freely as if no drug is in the eye. And when you ask the child again, then the child confessed that she's actually not using the eye drop. So this is a good way for you to know whether the child is compliant to using the eye drop or not. In the past, without this, it's hard to show the child this is what's happening to your eye. But having this video and show the child, look, this is your pupil, it kind of make them more willing to confess versus not having this, they will just insist, no, I did put the drop. This was the first case I realized the utility of MYAH pupillometry. It was 2 years ago. A child was started on 0.01% atropine, and the child came back complaining of photophobia, very bad photophobia. And when I look under the slit lamp, indeed the pupils are big. And it was surprising because most children on 0.01% atropine do not have photophobia and not that big of a pupil. So then I decided to put it on the MYAH, and you can see, as you can see on this video, the pupils are huge and the pupillary response is sluggish, even on 0.01% atropine. It convinced me that this child probably is suffering and I shouldn't insist on this child using atropine eye drop. And it was an older child and stable on the myopia control lenses, so I decided to stop the atropine for the child. Indeed, this is an additional step that is not in most clinical workflow. A lot of people just manage myopia just with refraction alone. So doing axial length is already one step on top of that. Doing pupillometry and axial length is taking that even one step further in terms of allowing you to truly monitor whether a child is using the drop or not, whether the drop is getting into the eye in a sufficient dosage, and also is it too much of a dosage causing side effects. So all this is very valuable information for the clinician to decide on how to titrate the eye drop.
Whether you're already a keen user of atropine or other myopia management practices, or you're thinking about getting started, pupillometry with MYAH could be the key to an entirely new dimension in your myopia practice. To find out more, head on over to the Topcon website